Welcome, everybody. This is a really exciting meeting. We have restarted the fall semester's keynote series. My name is Ziv Haskal. I'm the moderator and the organizer of this. And there are going to be opportunities for feedback, but not the type of audio feedback that we've been dealing with, but in the chat. So I beg everybody to stay muted except the speaker. So we've got an interesting title tonight. Checklists are not enough. Safety and quality in U.S. healthcare. Challenges from stratosphere to ground. I think this is going to become very clear very quickly what we're here to talk about, which is why, after all this time, are we still having problems that may be greater than we all realize in providing quality and safe healthcare for ourselves and for our patients as providers. And we have a very distinguished panel tonight. I want to briefly introduce them. We have Dr. Tracey Hoke, who is a pediatrician at UVA, who has served as the Chief of Quality and Performance Improvement at the University of Virginia Health System since 2013. She also has a graduate degree in outcomes research from Hopkins School of Public Health and has been a medical officer at the NHLB and NIH. Dr. Arun Krishnaraj, who is an associate professor of radiology and medical imaging at UVA and the vice chair for quality and safety, brilliant on these matters with research that focus on patient-centered care, lean-driven processes, artificial intelligence, use of social media in radiology, and healthcare policy. My decades-long friend, Dr. Michael Dake, who is world-renowned as a physician scientist, innovator, inventor, author, cited upwards of 30,000 times, who has served and continues to as the senior vice president for health sciences at the entire University of Arizona. And as a special treat, and as the very reason that this that I was interested in doing this, is we're kindly joined by Andy Pasztor, who's a former aerospace reporter for the Wall Street Journal. He's writing a book about the history of air safety, recently retired from the Journal, but he's covered aviation since the 90s. And he wrote this extraordinary column in the Wall Street Journal that sort of piqued my interest in this. By the way, he also wrote the 1995 book, When the Pentagon Was for Sale, Inside America's Biggest Defense Scandal. Thank you to all of you. I'm going to take the slides now. So we're going to view this as a somewhat informal conversation with a lot of topics that we want to cover, but to set the stage, we're going to ask Arun to start us off with a little bit of information.
Great, thank you, Ziv. I think we can use some of the technical difficulties as a metaphor for why is it so hard to get this right. We've been doing Zoom for about 2 years and we still can't seem to figure it out. Well, we've been doing it here for 150 years, at least the modern version of it. And it's still very dangerous. We still make lots of errors. Much of that has to probably do with the culture that exists in medicine and how that may differ from safer industries like aviation. And I'm most excited about talking about future directions, how we can mitigate some of these errors and really create sustainable solutions that move us into a better and more healing space. So at the end of the 90s, the Institute of Medicine, now known as the National Academies of Medicine, published this seminal paper called Error is Human. And in it, they highlighted the amount of errors that occurred in hospitals, many of which contributed directly to patient deaths. They pegged the high end of that number at almost 98,000 preventable deaths a year. And to put that into context, that would be the equivalent of a jumbo jet full of passengers crashing every day for an entire year. We're going to talk a little bit about aviation, and Andy's going to give us great insight based on his background and his Wall Street Journal article that talks about the aviation industry. But just think about that for a second. How many Americans get on an airplane if a plane crashed every single day? The FAA would not have it. Congress would not have it. There would be great uproar, and people would be pushing and pressing for change. Well, in 2015, the Institute of Medicine had a follow-up report about diagnostic error. And in that, they said, even after all these changes we put in place, diagnostic error contributes to up to 10% of deaths in hospital. And another striking statistic is that nearly every single American will experience at least one diagnostic error during their lifetime. And who knows whether that diagnostic error will lead to something catastrophic. But how can we build a better system? What can we learn from the aviation industry? And more important, what haven't we learned from the aviation industry? So I'd like to segue now to Andy, who's much more knowledgeable about this. And as you've heard from Ziv's intro, someone who's acclaimed in this area, who wrote a very provocative and interesting article in the Wall Street Journal. So Andy, why don't you take over at this point?
We'll have you bring your sound up, Andy. And on screen, you can see the article that piqued my interest, certainly, and led to the formation of this. Andy, are you with us? I think the plane has lost contact with the air traffic control.
Can you hear me now?
We can. I think we can hear you. Yes.
You can. Good.
Yes.
Good. So I'm really glad and privileged to be a non-medical person talking about this intriguing intersection between aviation and medicine. And to put it into a little bit different context, the revolution that in aviation safety has been produced by a number of factors, and we can talk about some of them. But first, we should recognize what progress aviation has made. In the US, scheduled airlines flew roughly 9 billion passengers, that's B with a billion, over the last 12 years, with one passenger fatality, not one fatal crash. There was no fatal crash. One person was hit by debris from an engine that exploded while the plane was in cruise. That's the extent of the revolution. And indeed, in some years, worldwide, there hasn't been a fatal crash of a major jet, meaning bigger than a commuter jet that you're used to. So how did aviation accomplish this? And I hope we can talk about why it is that healthcare has not been able to achieve anywhere near these kinds of successes. So first of all, a very robust, extensive, and systematic data collection, sharing, and analysis system with the lessons learned distributed widely throughout the industry, including the regulators. And that has been one of the major elements of this revolution. Number two, it's the ability to interview participants in detail, meaning pilots, mechanics, air traffic controllers, whoever else was involved in an incident, particularly a near miss or a close call, as some people would say it, and those participants willing to talk honestly and fully about mistakes that were made. And most importantly, if they did it, if they were not on drugs, if they were not abusing alcohol, and if they didn't act in a clearly reckless manner, if it was a good faith error, the expectation is in the industry now that they can avoid major punishment, because the idea is to explain what happened, to understand what happened, and then to move forward. And one of so the question is, why haven't these principles been so widely adopted? Or they have been adopted. There's been lots of talk about these principles from administrators, hospital administrators, medical groups, physicians, all sorts of organizations. But why hasn't there been
All right, everybody mute yourselves. We lost you.
Are you there?
You are. Somebody is unmuted.
Muted.
I believe it's, I think it's coming from Andy.
Andy, you may have two sources reporting. You may have two accounts logged in. We'll ask you to turn off one of them. You might have a computer and also your telephone. We're going to give you a second to work on that. And we're going to circle back to you in a moment to try to kind of understand that gap between why airlines have successfully done this extraordinary work, and yet medicine is still, I think, much further apart than we are. So I think while we wait for you to get back in and fix the AV offline, Tracey, here's a couple of your slides, please.
Absolutely, and thanks for the opportunity. I'll try to talk a little bit about what we have learned from the airline industry and what has been put into place in healthcare. And as Andy has pointed out, we haven't been able to replicate processes and environment as exist in the airline industry and in other high-risk industries, nuclear energy and aluminum manufacturing, et cetera. But we have embraced many of the principles. I'll start with the concept of robust voluntary reporting. One of the things that is expected nowadays as is regulated across the industry in the US is that every hospital have the ability for internal quality reporting. Our hospital, for example, receives 13 to 17,000 internal quality reports per year. Some of them are pretty pedantic and others are quite alarming, and they are reacted to in many different ways. As Andy said, one of the ways that we react to serious adverse events is to form a swarm, so to speak, of experts in the area of care delivery, in experts in improvement, and with those who are at the point of care when the event occurred, so that we can capture perishable information and really understand the processes that led to the event, thinking that it is less a person event and more a process event, and that we might have a chance of hardwiring an improvement if we really understand it deeply. In addition to internal quality reporting at every institution I know of in the US, there's also a requirement by one of our regulators, the Joint Commission, for sentinel events to be reported, and that is protected federally. It's also protected in our patient safety organizations. These are organizations that hospitals voluntarily join, and we share adverse events, sentinel events, RCAs, improvements. We share openly with each other because we do enjoy that protection, because in our industry we have a fair amount of fear of litigation, whether that be aimed at a provider or aimed at an institution. And so we've been able to have safe spaces as organizations go in our internal reports, our regulatory reporting, and our voluntary patient safety organizations. I will say some places have done even one step better. Children's hospitals in the state of Ohio, for example, agreed not to compete on safety years ago, more than a decade ago, and through legislation, we're able to protect their communications and their ability to share both near misses, good catches, adverse events, RCAs, and improvements. And that is yet another way that we've learned from the industry that made airline travel so safe, that if you share what you know before it happens in another institution, you might be able to hardwire an improvement in your own. And then finally, there's a fair amount of voluntary or involuntary reporting that happens through benchmarking, whether that be through Hospital Compare, the CMS publicly available database, or any of the benchmarking organizations that utilize that database, from US News and World Report to Leapfrog to the value-based purchasing programs that we all participate in. A second sort of structure piece that we learned from the airline industry is that you need to think both reactively and proactively in this business. That quality reporting, patient safety offices, risk management officers, and performance improvement need to work together. That there is a very reactive component once events have occurred, that they are reported, investigated, root causes are understood, and then improvements are hardwired into the system. But there's also a proactive piece of understanding what the next best practice might be and bringing that into your organization through a rigorous process, now most commonly called implementation science. And so at our organization, for example, in our daily management system, which is a set of practices involving huddling, visual management, problem solving, and escalation, the teams are charged with both, with understanding what happened in our industry, our areas, our business yesterday, what went wrong, what was unexpected, what would we have done differently if we had had the chance to design it differently, and then what might go wrong today and tomorrow, and what could we do to prevent an adverse event or an unexpected outcome. And again, thinking less magically and more rigorously around improvements. I will tell you, having been in this business for a long time, education is not an intervention. Hardwired improvements that make the safest thing to do the easiest thing to do are the way to go. And taking advantage of systems like your electronic medical records and the ability that they have to prompt the right things, so to speak, are ways in which teams like mine can help hardwire safety into a very risky and volatile environment.
Tracey, you made a provocative statement there. Education is not an intervention. You want to spend a second on that, because we think that education is the direction to better practice and improvement and smarter people in systems as well. Clarify for everybody why it isn't, or how you mean.
Absolutely. So education is important. We expect that all of our providers, team members alike, come educated in their area of expertise and are experienced to the level that they've achieved in their training. If you want to make change, you can educate once, and for a minute, a moment, a day, a week, team members might remember. In an academic medical center with the revolving door of trainees that we support, and we are happy to do that, with the now highly stressed environment of nursing and other team member shortages across our industry, our traveler numbers are higher than ever before. If you count on education, you will inevitably be behind the times as soon as you've educated. The minute you've given your best advice, it's either misinterpreted, forgotten, or missed the next person who's going to be on call that shift. And so my job involves trying to figure out how to hardwire into our interfaces every day. And the electronic medical record is probably my strongest lever. The prompts or the information or the education that you need in the moment when you're taking care of a patient. I think everybody knows that those annual educations that we do and the things that we do come board review time are important, but they don't prompt our activity moment to moment, in the moment, when a risk may be at hand that we don't even see.
So Arun, you and I were talking about this several times beforehand in terms of your experience in MGH and how you sort of view your experiments with using the EMR to prompt more defensive actions, if you will, preventing physicians from causing harm, but also proactive, instructive ones. Do you want to share some of those to build on what Dr. Hoke has just said?
Sure. A couple examples, one that is more radiology specific, but applicable to all of healthcare. And the second that deals with emergency care, which is often high stress and a deluge of information. So the first one, many patients in a hospital may be ordered, they may have an MRI ordered to come down. As we know in radiology and others are probably familiar with, the presence of metallic implants, especially in certain locations, can make that exam difficult. Patients traveling from the inpatient ward down to the MRI scanner may not be able to be conversant in being able to relay the necessary history regarding any metallic implants they have, and they may not have family members to be their advocates to be able to voice that as well. So we designed a system that would use natural language processing to search the EHR for any relevant terms and bring just those notes to the front so that the technologist at MRI or the radiologist could then question specifically about that and explore it. Again, this isn't a fully automated system to be able to make the decision, but help filter through all the deluge of data that exists in the EHR to bring that relevant information forward. And following up on that theme, in the emergency department, there were simple errors being made regarding how to take care of a patient with diabetes, because diabetes was represented as diabetes rather than type 1 or type 2, which the treatment algorithms are completely different. And these mistakes were being made because, again, the physicians were being overwhelmed with an enormous amount of information. So we built physician specialty specific dashboards that would search the EHR for those relevant terms and highlight those and bring that to the attention of the physician, nurses, and other caregivers. And both of those proved very successful in trying to reduce errors. And I like to build on something that Tracey had said about you have to make the easiest path, the path that people choose to do the right thing. And I think this builds on the body of work that we've learned from folks like Richard Thaler and his book Nudge, and Danny Kahneman and Amos Tversky, who really pioneered the field of behavioral economics, in which the default pathway is the one that most people will follow. That is the one that you want to make the one that is the preferred one. And the way you do that, as Tracey was saying, you can educate until you're blue in the face, but especially at a training hospital where there's so much turnover, you have to make doing the right thing easy. And oftentimes doing the right thing in a hospital is challenging, and it's a complicated environment. And I think that that's one thing that we can probably adapt from economists is how do we learn how to nudge people in the right direction?
You know, I'm struck recalling the Veterans Administration reorganization a few decades ago. And one of the earliest EMR systems. It was sort of the golden era where at one point, any veteran at any hospital in America was almost 3 times as likely to receive an aspirin in an ED when presenting with MI symptoms than in an academic center in the US, because they had, at least at that rudimentary phase, hardwired it. But I also remember when we were talking and you had described the way that when I go on Amazon and I buy something and pops up, 98% of people also bought this. And, I'm clicking in to be 98.1. And you had described the situation in which we might be able to harness these types of language processing or algorithms to present doctors things at diagnostic situations. You want to build on that?
Sure. Again, building on what Dr. Hoke was saying about best practices and making things easy is sharing information among peers so that people understand that when a certain situation presents itself, that there are many other steps that often go along. So this will date me a little bit, but when Ziv and I were speaking about this, when you order a DVD player, it needs a cable to connect from the DVD player to the TV called an HDMI cable. Now everyone streams, but in the era where you actually had physical media, you could order the DVD player, then you get it home, you'd open it up, you were super excited, you couldn't watch your movies because you didn't have the cord. So the recommendation would come up and tell you not only did a majority of people order it, but they would show you the package price with it and make it easy. And I would love to see electronic health records do the same thing, especially in environments like the emergency department or the ICU, and also to link that with the outcome data to show that 96% of the time when this set of laboratory studies and imaging exams were ordered, when these particular clinical parameters were met, it resulted in a better outcome. And then that system can iterate on itself and you can further refine it and continue to improve the best practices and create the default pathway and make it easy for physicians. Because right now, the job of physician is overwhelming and super complex. And the amount of literature that comes out every single day is impossible to keep up with. So we have to figure out a way to hardwire and to harness all that information into pathways that are easy without overwhelming a physician every time they log on that someone hasn't had their flu shot or their pneumovax or this or that, and you're trying to take care of them in a trauma situation, clicking through whether or not they've had their pneumovax.
We don't want to feel successful. We want symptoms that are going to service, systems that are going to serve this up. So, Andy, we're glad to have you back through the technical aspects of it. But
yes,
isn't it just too far of a gap to say that mechanized systems with automated systems that allow planes to land can possibly cross over to solve what seems like an infinite problem of variations in medicine? I mean, how much can we actually learn from this when we get to these sort of ground level errors, or what parallels do you see?
I think that's absolutely correct. It's hard to see how mechanical systems and even artificial intelligence in the near term will provide answers. But I think we should take a step back, because the revolution in aviation, of course, it involved all the data mining and all of the things that we've talked about and have been talked about. But most important of all, there was a commitment from the top of the airlines and the top of the regulatory chain and the unions that they would cooperate in a non-punitive system, and indeed that the very top people in the airlines would be devoted, committed, and mandate that a just culture be installed in these airlines. It took many years. There were lots of stumbles, but the safety officers of the major airlines in the US report directly to the CEO or the chairman of that airline. And so therefore there's a direct link. And I think that fosters a sense of everybody from management to the employees absolutely willing to participate in the system, even if it costs a lot of extra money, even if it means grounding some planes, even if it means some passengers will be delayed. And there are lots of examples of that. And the one example that I like to talk about with my friends, which is a very good summation. United Airlines, maybe a decade ago, installed electrical systems in the cabins to allow people to plug their laptops into these outlets. The chief, and this was a big selling point and a big marketing point. The chief of maintenance and engineering at United at that time decided that these were not going to be used until the wires were moved a little bit further apart to make them less safe. He thought there was a hazard. There was no incident. There was no accident. The FAA never knocked on the door of United to say, you've got to do this. But there were senior people who said it's not worth the risk and were willing to take the hit commercially and financially, because it costs some money, of course. And I think that rather than looking at the specifics of the mechanical systems on the aircraft and even the training of the pilots, maybe one of the things that could be worked on and may be missing from the healthcare arena is that top-down commitment, clearly enunciated, always stressed to, as somebody said, doing the right thing, but doing the right thing every time, all the time, even if it creates problems, even if your colleague thinks that you're overdoing it or whatever. I think that's one element that hasn't received enough attention in medicine and could provide some significant progress.
So, Mike, I want to bring you in as somebody who has worked at a systems level and had to create very urgent responses to a population of, I think, upwards of 50 or 60,000 students under crisis mode where none exists. When you look at this as someone who's been in healthcare for decades and now in this role, how do you see that cooperation developing? Or
I think got to become a priority. It really must, and at all levels. Let's think about what is now a common practice and really ingrained, almost like a spinal cord reflex in most hospitals. That's a timeout process, right? Everybody does that. You can't avoid it. It's de rigueur. It is done. I mean, I look at where should we really have the biggest bang for the buck? Where's the big impact? And I'm not an expert in this, but if you look at ICUs, the high Apache predicted mortality group, you probably won't impact. The low, you won't probably impact. But in the middle, there's a huge group of people that could potentially benefit. And like Arun was saying, popping up on an EHR. What's been the duration of the Foley catheter? What's been the duration of empirical antibiotics? What's been the duration of, say, a central venous catheter? All these things, those can be real impactful interventions, and I think it's up to the systems to really, leadership, to really try and go beyond these checklists and make it happen, I mean, that's what it takes. And Andy hit upon it. It has to be a priority. I mean, I think we know what needs to be done, but it doesn't get done, right? Checklists are not sufficient. Prompted checklists, clearly work better, but nobody kind of, it just is not something that is yet like a timeout.
yeah, we have fire safety included in our checklist before surgical procedures. And it just doesn't resonate as a piece of useful information that creates an action, maybe because it's too rare an event, like it's the wiring that Andy discussed, or because we're not checking the right things. And we have, by the way, a comment from the chat from one of our attendees, which says the problem exists with diabetes. There isn't a good systems level transparency for our diabetics. When insulin is held at our pharmacy, the pharmacists don't know if it's type 1 or type 2. So basic piece of information that could be a piece of data identified, or what anticoagulant should be immediately given in the ED at the time of a presentation with a blood clot, something that affects, a few million people a year, and yet we still have to educate rather than innovate and create processes like Dr. Hoke was saying.
I think part of it too.
Checklist design is an impediment. And so, as you said, that leads to fatigue and people just thinking it's kind of not relevant. So that's something. But what we've done here at the University of Arizona, I am gone all in on interprofessional teams. And we talked about education isn't really, the answer here, but it's still important, as Tracey said. And so we do simulation exercises from pandemics to natural disasters, whether it's a flood or a wildfire or a earthquake or whatever, where we force public health, nursing, we have simulated pharmacies, we have individual rooms of simulated pharmacy, simulated ED, simulated ICU, simulated labor and delivery. So all of these things can be worked on in teams. And hopefully that at least gets ingrained in the trainees, if not the faculty and staff, that they're thinking about these things.
Tracey, it feels like you were about to go right into that on the last block of your slides and build on what Dr. Dake had just said. Is this a good time for that?
Absolutely. Absolutely. Yeah, I think the one thing I want to say is that maybe I've been in a privileged position in my professional lifetime, but I've only worked for executive vice presidents of our university who have put quality and safety first. Rick Shannon said it every single day and resourced my team in every way possible. And Craig Kent has said it in a different way, which is I expect it. I expect it, and I expect to hear from you when we need to do something different. And I will tell you a couple of interesting stories over the years have led to huge amounts of resource reallocation because somebody from my team recognized a risk or recognized a trend and called it out before it hurt a patient. And I will say that I feel lucky to have worked in the organization where I have worked, because our voice is I think paramount. And at the CEO's cabinet, when I'm able to eloquently describe with data and understanding of best practice a risk or even describe a good catch, so to speak, everyone at the table is ready to hardwire it. And so I think at least in our institution at this time, 20 years after the IOM of old published that famous book, To Err is Human, we live in a different environment. I'm going to talk a little bit about reducing competition on safety, and then I'm going to prompt Arun to talk about the environment we live in from a cultural standpoint, because I actually think our impediment at this moment is less administrative or leadership focused than it is peer focused at the point of care. I think that's a piece that we need to work on. But I will just say again, from the industry's standpoint, we have taken great strides to reduce competition on safety. I can tell you in this state at the VHHA level, we pledged easily 15 years ago not to compete on safety, to share all of our artifacts, to share our learnings, to cooperate with each other. And I can tell you that aside from the hardwired communications that we have through the various different ways we can share, I get a call about once a week from someone in our state representing one of our healthcare systems saying, I just want to run this by you. This happened, and I think this is going to solve the problem and prevent it in the future, or this is a risk and I don't know what to do to solve it or prevent it from happening in the future, and tell me what happens in your place. And we all know each other and we're happy to share because our primary goal is to keep our patients safe. I will say again, also, some very creative things have happened across the country. I mentioned the children's hospitals in Ohio. They've provided, lobbied for, and were able to achieve legislation in their space to feel beyond protected from a litigation standpoint in sharing. And that is a risk in this industry that we are still struggling with. Our providers are worried about litigation, our hospitals are worried about litigation, and that disconnect between punishment and blame, so to speak, and transparency and willingness to acknowledge and share and describe is a real struggle for us. And then finally, this bit about measurement. Every agency that tries to measure hospital safety is dependent upon, at this point in time, either surveys or publicly available billing data. And I will go on record saying that billing data is no way to understand how care was delivered. It is filtered from information found in records and distilled into codes, whether they be DRGs or CPTs or others, and then reflected back from the lens of a team focused on adequate and appropriate billing practices. And I think that's a real weakness for us. In all of the national committees I've sat on around measurement and benchmarking at the CMS level, I always say I am willing to put more resource into documentation and abstraction of information if it means I'll have better peer comparisons, because that's what I really want to know, is what actually happened and how sick were those patients and how comparable are they from a population standpoint. And that's something else in addition to the litigious environment that we live in that is holding us back, I think, at this point.
So Tracey, I was very excited to hear that you've described a cross Virginia sort of collective of sharing information, because what occurred to me as you were speaking is, so this is great in large systems where there's this kind of excellence and commitment as we have, but then you come into a 250-bed hospital in a state you've never been at with acute appendicitis, or your parents admitted, and there aren't the resources for this, and there aren't the systems, and they aren't necessarily calling you up on Monday morning to say, can we debrief? You know, what are those things that are going to assemble, whether it's teams or, you know, or systems down to that ground level for people?
Yeah, I think this is where our EMRs have failed us nationally. So more than half of Americans have an EPIC MRN, medical record number. And that means that you would imagine that if you came to UVA for your care of any kind, and then you showed up, as you say, in a non-Virginia based critical access hospital for appendicitis, someone ought to be able to look in their EPIC record and understand what your diseases are, what your medicines are, what your risks are. And that is not always true across our electronic medical records. It's getting better, and I think it's getting better because much pressure is being applied to that industry. But I think that belief that if we all invested in these records that we could all share, we would all be able to provide better care in any venue within our country has not quite come to pass. And that is yet another weakness, I think, in our industry at this point.
I'd like to just very quickly jump on a point that Tracey made, and that is that, yes, a statewide database is wonderful, but what aviation has managed to do is create national databases and to a large extent international databases. And so the end result is that there's a huge volume of information. The same people routinely look at the data, assess the data, figure out how to deal with the incipient threats, and then a month later or 2 months later come back and actually determine whether those steps were adequate or more needs to be done. And I think from my vantage point from the outside, having thought about healthcare in relation to aviation, and certainly in the last few months, that is a huge difference between the two worlds. And the litigation aspect, the data that the airlines collect, is protected from the litigants, and so therefore they're much better and much more easily shared. The data is much more easily available, but that would be a huge difference, I think.
Do I just blow up a bomb here and say that, did you just suggest that tort reform is going to be a necessary? I'm sorry, we can't go there. I mean,
the meaningful use legislation that really incentivized the adoption of electronic health records across the United States was in its main intent to create a nationwide interoperable health information system. But what ended up happening is you just had these little cottage industries of EHRs. Now we have a few major players that can share with each other, but we still struggle to share something near and dear to my heart, which is imaging. So we see duplicative work, we see people pursuing things unnecessarily, and errors occurring because of the simple ability to exchange information across two systems. And while it's improving, the intent was for it to be there from day one, and it hasn't been, and we're retroactively getting there. And that's really frustrating. The systems that Andy is familiar with, that the FAA uses to share information, are much more seamless and much more timely than what exists in healthcare today.
I suspect that every healthcare provider on this call understands that kind of caste system when a trainee says outside hospital, and the presumption that it's a second standard of care that's being delivered, and everything begins afresh when you've come to whatever mecca you happen to be in, be it a community new hospital or the mothership of your system as well. This sort of assumption that we duplicate and reduplicate and recreate errors or repeat is also a closed-mindedness to to assuming information that's going to be brought from larger sources as well. You know, there's sort of belief in the one, and we're the one at this given moment.
Steve, I was going to ask a quick question of Tracey and Arun. Are we making any progress when it comes to medicine reconciliation, which always seems to me to be a big bugaboo when, you know, not necessarily in the hospital so much, but when people are in the outpatient setting and are on 3 medicines to treat the same thing and no one knows what they're on. But is that becoming less of a problem, or does it still exist as a major error source?
I'm going to invite Amber Inafuentes to speak to this one because she just won our Best Hospital Project of the Year award for this work. And the venue in which she took MedRec on was the discharge from a hospitalized patient to a skilled nursing facility. Amber, do you want to talk just very briefly about the key elements of the work that you guys did to make that a safer handoff? I think she's still on. We may need to unmute her.
We'll see if we can get her there because I'd really love to hear that.
Yeah, I can talk a little bit.
As we're trying to see if we can get Amber in, we had a question as to how HIPAA actually affects our potential to look at this data. In other words, what does de-identifying data at a large scale actually mean, and what are the barriers to that, if any?
Yeah, so HIPAA is definitely an issue in terms of sharing actual case events or medical records, but we are able, certainly under our federal protections and the patient safety organizations, to share our cases without some of those identifiers in a protected way. I think ultimately, in order to share at the level that the airline industry shares, we would have to have a different kind of protection than we have today. We're definitely able to share trends. We're certainly able to share population risk and mitigation strategies and outcomes associated with those strategies. But it is, if you want to talk about a very specific case, a specific patient, a specific event, a bit of a conundrum in terms of asking for help or an outside review. We do it from time to time, and it requires a legal agreement with the external entity and or reviewer if we're looking for other input.
You want to spend a couple? Sorry.
I'm sorry. Airlines are able to get to that specific detail. It took them a long time, but now they are able to look at specific flights, specific pilots, specific incidents. And the reason they can do that is because they have a trusted third party that gets the data, aggregates it, and then provides the specifics to the participants in a way that can be best used to look at the root causes. And also legislation. Some people think that legislation will be a solution to the problems of the medical industry and the healthcare industry. I mean, I think if you look at aviation, all of the progress has been made despite what Congress has tried to do. It hasn't been mandated. It's been all voluntary from the ground up because people realized they needed to do something.
And Andy, who pays for that across all airlines? How is that funded? Those efforts?
You and I, by flying and by paying taxes. I mean, it's an expensive for the airlines. It's quite an expensive operation, and the big ones and the good ones spend a lot of money on it. Just as in healthcare, the smaller ones and the ones that are struggling and some of the commuter airlines don't spend as much money, don't have as sophisticated systems. But it's the FAA participates, but it's mostly airline funded. They decide that it's important, and they provide the funds for it every year.
So I remember, and I'm sure I have the numbers wrong, quite some time ago, hearing that the price of a GM car was perhaps 15% of employee healthcare plans. And even if that number is off plus or minus at the time, what you said makes me think that the best drive to reduce healthcare costs, which means is our employers with tremendous amounts of money is at risk because that's passed into the product line. Are we saying that this is going to come from large scale industries, for example, from Amazon workers, which is, one of the biggest employers in the US, to reduce our package costs? Or are we expecting that this is going to be top down, 20 years of governmental infighting for legislation to share database?
I still think we're going to need tort reform if we're going to actually put this together, but that's my own.
You want to touch on this slide, Mike?
Sure.
I don't know if you wanted to say something, otherwise we'll go with this.
I'll just share this. This is from the Digital Quality Summit, from a presentation that was made from the CDC, just to show what's expected of modern health systems today in terms of improvement. And it's a lot, so to speak. It's this concept that if we start at the top left, organizations are expected to be constantly looking for new best practices and then building hardwired prompts into their EMRs and other protocols and other processes to then learn and study those processes and outcomes and share in an aggregated, de-identified way outcomes, so that if one region, area, state, system has learned something, it's available to others. And that term implementation science has really exploded in this arena, and many journals no longer have quote quality series. They have front page articles in this space because it's deemed to be so important. Again, you wrap it all up in a culture of willingness to both share and describe the very detail of the events that you were a part of. From those learnings come things like global standards. That's when the Joint Commission comes to visit. They're looking to see that we're holding the very basics of what safe healthcare is thought to be, and then moving into the more elegant space of digitally understood structured data, so that we can have very large databases with the kind of detail that allows us to understand risk, to risk adjust, and then to connect risk mitigation and outcome in a way that we can learn yet again, provide trustworthy evidence, and then synthesize it and start all over again. So it's this, it's sort of the new way of thinking of the cycle of continuous improvement, is that it's both research and learning and implementation and cooperation.
So how about if we take the conversation down a little bit, a little closer to sort of that ground level of the everyday, and Professor Krishnaraj, we could get to talk about the humanistic aspects of what we face and how do we, incentivize each other to behave better and reduce errors.
Yeah, no, I completely believe in implementation science. I think there's a lot of white people like Dr. Hoke working in this space, but we also have to be cognizant of the fact that we're dealing with human beings and the way that human beings interact with each other. And Andy brought up the point of airlines and being voluntary and having a just culture. A just culture is one in which people are open and willing to report mistakes. They don't feel shame from those, but see those as opportunities to learn. In hospitals, we have distinct and very large power gradients. A first-year resident is unlikely to speak up to the chair of surgery if he notices the chair of surgery is not washing his hands before he enters into another room. These kinds of simple things are what I believe holds the healthcare industry behind from being able to make the progress that the aviation industry has made. And we can say it until we're blue in the face that we all need to be egalitarian and be on the same level playing field, but that culture doesn't exist. And that culture leads to communication breakdowns. And the other key individual who's left off of that power gradient or at the very bottom is the patient. There's an asymmetry of knowledge. The physicians and the physician teams and nurses have all that information. I am constantly on the phone with friends and relatives trying to gather information for people who've been hospitalized or sick, and the amount of information that they understand about their current situation, what the next plan is for their care, when they may be discharged, is completely lost on them. They're very rarely given an opportunity to participate in true shared decision-making where they understand what the next step is, and they become overwhelmed and frustrated. And then a few other points that you have on here, the concept of tribalism exists as well, where ED docs and radiologists and infectious disease docs see themselves as peers and may communicate with each other. But between those groups, it can be often challenging to be able to communicate information. And when those communication loops break down, errors occur, no matter how great a system that you set up. And then the last point I want to make is, we see the EHR as this source of great data, and it is. But I have this is not an Apple ad, but an iPhone in front of me. And many people have these iPhones. You'll notice there's 4 buttons on the bottom, the icons. That hasn't changed in the 10 years or so since Apple has had their iOS. Now, they've made improvements. You can swipe this way and that. But when you approach a modern EHR to do something simple, you are accosted by 5,000 different choices, buttons, bars, sliders, this and that. And there's a ton of literature that speaks to the fact that human beings do not multitask well. If we do 2 tasks, we do each task 50% as well as we do a single task. But we're asking people to make decisions where people's lives are on the line and use systems that create the level of cognitive burden that prevents them from being able to do that default pathway to doing the right thing. And the pressure on the AHR industry to improve that just isn't there. And I think that, improving the culture, improving the communication, breaking down the walls of tribalism are the way that we get to the point where we can have the success that the aviation industry is experiencing.
Well said, Arun. Tribalism is even an issue in terms of daily decision-making as to what surgery or what procedure to do, because it means moving outside of your cocoon of where you're comfortable and releasing people into others' care. You were going to, did you want to expand further on how?
Sure. So I'll make one last comment because I want everyone to kind of be able to chime in with some closing comments. One of the things that, our regulatory body is the Joint Commission. That for the airlines is the FAA. When the FAA noticed that a certain Boeing airline, one of the major players in the space of aviation, had an airplane that had flaws, they were grounded. That hurt their stock value, that maybe pushed more business to Airbus, but they were grounded. The Joint Commission is something that, and I hope Dr. Hoke doesn't get upset with me, it's something where we run around with our hand, like our hair's on fire and we're scared and we have to do this. But is the Joint Commission going to shut down the University of Virginia, the University of Arizona, because they noticed something? It's almost like we're in a situation that is too big to fail. They'll give us 9 and 10 chances and they'll keep coming back. And while that's great, that's not how the airline industry operates. If they identify a plane that's not working well, even if it's from Boeing, that plane's not going to fly. And I don't know if we yet have the stomach to do those kinds of things in healthcare. Many people feel like these things they do are just to check boxes. They don't see the connection between doing the right thing and seeing the outcome. In the 1850s, Ignaz Semmelweis proved definitively that they could reduce puerperal fever if people wash their hands. It's been over 150 years, and people still walk into patient care rooms and from patient to patient without washing hands. That's a travesty. I think we have a long way to go, and I think there's some simple things we can do to get a lot better.
Mike, Tracey, I can't help but ask you how COVID has focused these types of thoughts as you've thought of health around a single entity that has plagued us, and whether this has any particular lessons or reflections.
I'll just say a few things about COVID. It has taught us an awful lot about innovation and given us the ability to act within a time frame that our industry is unfamiliar with. It's one of the first time in my career where regulations were paused from time to time to allow us to take care of a patient population that was both variable and overwhelming in volume. And so in some ways, it is the best thing that's ever happened to us because it has really taught us to think differently and to to govern differently. Where it became, I think, a real risk for patient safety is that this is a novel disease that at the beginning we didn't know what to expect from or how to take care of it as well as we do now. We also, because of some of the limitations of care delivery for those patients, were unable to do some of the best practices. Think of things like central line maintenance and Foley maintenance and things like that. Very difficult to do in a prone patient. And then also the stress that's been placed on our workforce is it's immeasurable. The fact that our workforce is leaving the industry and or jumping from hospital to hospital to find a better situation and leaving the inpatient arena where the sickest COVID patients are has left us with a weary workforce that is trying to do their best for themselves and their patients, but under a stress that we've not seen in my lifetime.
Just say, I don't want to be redundant with what Tracey said. I totally agree. And I think there is some silver lining with COVID, that it's focused us on a lot of things we didn't think about before, like supply chain, like stockpile. Things came up. We didn't even know where these ventilators are. Over the last 10 years, the healthcare industry has adopted a just-in-time philosophy. We didn't have PPE enough, and where would you get it? Well, we know it exists, but where is it? Instead of a just in case, we used to have a just in case. So we've tried to prepare, and preparedness is now obviously what we're seeing centers kind of proliferate all over the country now about pandemic preparedness, disaster, getting prepared for that. And that's good because we needed this. It's going to happen again. And I think we got out of that and sort of into a just-in-time mode that disadvantaged us during the pandemic.
I would like to get back to one point, if I could, which hasn't been mentioned, which is really important. The airline industry didn't get this safe because of generosity and a highfalutin view of the world. They got this safe totally out of self-interest. In the early 1990s, the leaders of the industry, both on the airline side and the operations side, the manufacturer side, decided that if the number of plane crashes per year continued at the rate at which they were going and traffic grew at the rate that was projected, the public simply wouldn't stand for it. I don't think that has occurred in your world, and I think that's an important difference because they decided it wouldn't be allowable, they couldn't stand it, and then they actually got around over many years and then through many difficulties, they changed the culture. So now even in Asian airlines, where the power gradient between the captain and the co-pilot is huge, was huge, and still is huge, those co-pilots have been told, sometimes by the chairman of the airline in videos, you need to speak up. If you can't land because it's not safe, you have to tell the captain, even though he has 5 times, 10 times, whatever, how many times, many hours as you do, and he's a veteran and he used to fly fighter jets for the Korean Air Force. But if you're landing in a place that's not good or in a way that's not appropriate, you need to speak up. And so I think those two things were very important in creating the safety record for the US airlines, but also worldwide.
Wow, well said. Fabulous conversation. I want to be sensitive to everybody's time tonight. And I guess perhaps just a few minutes for all of our speakers in case you want to make some closing comments, either on where we can practically go or what we might be doing on the ground level as providers ourselves, or blue sky as well. And in no particular order, Dr. Dake, if there's anything that you'd like to provide as a capper.
Well, I think, Ziv, it's been fascinating conversation, and it's certainly, hopefully, we come out of this with an awareness that's elevated over what it was going. I have a lot of ideas just from hearing the conversations, and tomorrow I'm going to start exploring them, but much to do. I totally agree with Andy that we still are far, far away from solving the problems that exist in healthcare, but there are lots of tools we didn't have before. So I am looking forward and comfortable that we will make progress. So
Andy, going to you, and you've been looking at this from outside the church. Where do you think we can actually get to?
Well, I think that a third party outside are looking at some data and some trends might be a good step. And there's been talk about creating an NTSB type of body for medicine. It created lots of problems on the legislative side, lots of problems with buy-in from hospitals. But from my sense on the outside and as a reporter, it's always good to have third-party oversight. And the aviation industry has it with the National Transportation Safety Board. It's a bully pulpit. They are reactive, but can be proactive and have been proactive when they see things that need to be done before the regulators get to it. And so, I mean, I think there may be some value in thinking about some kind of third party outside, not review of cases, obviously, but trends and larger picture issues.
And Arun, you would imagine that that kind of board is going to have top data scientists who are going to be able to understand how to analyze and extract, and also what?
Sure. And my research is in artificial intelligence. It's sexy, it's fun, it's in the zeitgeist. But honestly, if this is all going to get better, we have to wash our hands, we have to talk to each other, and we have to include the patient in the conversation. I think if we do those three simple things, we'll make huge strides. And I think a lot of effort is placed on the latest and the greatest and the cutting edge using the technology, and the technology should empower us. But these basic humanistic qualities that sometimes we've even moving farther away from because we're working in this digital world is what's hurting us. So that's my points. Wash your hands, talk to your teams, your colleagues, and include your patients in all the conversations you're having. Value their input and make sure they know what's going on.
So before turning to you, Tracey, you reminded me when I was a more active skydiver, I would get the monthly magazine. There were always incident reports as to causes of death, were ironically all described as cause of death impact. But the point was, is it was the number of dives. So anywhere from 7 to a remarkable number of skydivers who had 1,000, 2,000, 2,500 jumps, which means that's a full-time occupation. You aspire to live only to jump, and these people die. And it's always a loss of situational awareness and a complacency and an assumption that procedures are intact and your safety is assured, particularly because your systems have worked 2,000 times beforehand. So to your point of washing your hands endlessly and speaking up. Tracey, would you like to close with some thoughts for us?
I'll just say that I'm very happy to have been a part of this panel, that all of the sentiments that have been expressed are on point, and I have great hope for us as an industry as we move forward. And I think we have to remember that people count on us, and so we have to strive for perfection and not make excuses, but try to understand root causes as deeply as possible, and to hardware mitigation strategies when they can exist. And yet, I agree with Arun 100%, wash your hands.
Thank you very much, everybody. I'm very grateful for such expertise, and you're sharing your valuable time tonight with all of us, and for everybody who's going to be watching this in its recorded form, which will get up as quickly as possible on the UVA Radiology Imaging Keynote website. Thank you. Good night. Wash your hands.
Thank you.
Thank you.